Next I invite Dr. Jayaprasad Bhaskaran, our JP sir. He doesn't need any introduction. He is one of the pioneer surgeons of phaco in Kerala. I still remember his teaching in 1998. Do phaco in immature cataract through a well-dilated pupil. That was his teaching. But today we have small pupil, and sir will tell us how to do it with the rings and hexagons. Over to you, sir.
Thank you, Dr. Cinnamon, for this opportunity. I also want to thank Dr. Srini for this. Dr. Smitha, my wife, was extremely happy when she heard the topic, so that she doesn't have to remind me again and again about rings and hexagonal diamonds. I have no financial interest either in the diamonds or in the equipments and instruments I am going to share with you. So operating in a non-dilated people with experience you can achieve, but there is always, your heart is in your mouth and you always have the risk of going and damaging the pupil, damaging the endothelium, damaging the PC. And you do not know exactly where you have implanted the lens, and at times you may see surprisingly post-operatively the lens may be half into the anterior vitreous. And if you look at the challenges that the IOL, the iris hooks give you, you have to put multiple paracentesis. You can have subconjunctival hemorrhages, the eye will look red the next day. If your incisions are more limbal, then you can have subconjunctival chemosis, the fluid will get welling up, so visibility becomes poor. And the outer ends of the hooks can go and hit against the lids or onto the middle canthus, and then the inner side can go and damage the pupillary margin. And the people who propose and sell hooks say that there is a higher risk of infection with iris hooks, which I do not agree with. There are a variety of pupil expanding devices other than the iris hooks, which I have used quite a lot. And Malugin ring, Dr. Malugin incidentally is a friend of Dr. Cinnamon, and she always tells me to talk about Malugin, but 10 years back I used to bought at 6,000 rupees one piece, used on about 4 or 5 patients. It's for in my hands at least I feel it is really traumatic. So let me confine today's talk to just 2 of them which I regularly use, namely the BHEX ring and the Inova ring. Now these 2 rings in my hands gives consistently predictable outcome, and the constant pupil size that they give and the red glow that I get makes my life more comfortable in all types of cataracts, particularly soft cataracts. BHEX ring, as you know, is from Dr. Suvan Bhattacharya, my friend from Calcutta. We were together at Jimma, so 20 years back, 25 years to be precise. This ring is actually a thin nylon ring. It's very difficult to see, almost like a hair, less than 0.1 millimeter. It's very light, so it floats. And the overall size that you will achieve with this is a 5.5 expanded pupil, a stable 5.5 expanded pupil. And this has got flanges and small notches at the edges. So you have notches at the edges and the flanges. Alternate flanges, that is this one, this and this will go under the iris, whereas these ones will remain above the iris, and these notches will engage the pupillary margin. Notches engage the pupillary margin. The alternate flanges will go above and below the pupillary margin into the iris. So one of my first cases I will show you, few years, BHEX with Sinski's hook. Those days I was against this manufacturer selling the 23 gauge forceps. So I used to use a dial of the Sinski's hook, catch that central hole, push it down and gently tuck it under the iris. Always remember to inject OVD under the iris so that you don't poke onto the anterior capsule and create a tear. Then you go to the second one. I am struggling. Actually, this is a fast forwarded video. I struggle. This is a struggle actually. The first few cases are always a struggle with any surgery. Ensure that both the ends are engaged, both the notches are engaged. Now it is not coming out, the Sinski is not coming out. You go through the side port and tuck it in. You see that one notch didn't go in, so brought it up and now tucked. Now we come to the last one. The last one is the biggest problem. The biggest struggle is the last one. Brought it in with my Sinski's hook, bimanually lifted up the iris and tried to insert underneath. So that gives you a reasonably 5.5 mm hexagonal opening for you to complete your emulsification. It doesn't interfere, because of its thin profile, it doesn't interfere with your emulsification, cortex aspiration, or your IOL implantation. Here implantation is under continuous irrigation, not under OVD. And once that is done, the lens is in place and you are sure that the lens is nicely placed, then you can go with your dialer, and taking out is relatively simple. Pull it forwards towards the center, 1, 2, and then both the ends are released. Rotate a bit and bring it to the anterior chamber. Because it is under fluid, I bring the irrigation handpiece right across the anterior chamber and keep that nylon ring from coming up and hitting the endothelium. So I am keeping it right across, otherwise it will swirl and come and hit the endothelium. Go in with your forceps. This is a 25 gauge forceps from my VIA surgeon. Catch and simply take it out. This comes out through a 1 mm incision. And you leave behind a round, nice, reacting pupil. So BX ring produces minimal complications. That is the truth in my experience. Dislodging is possible very rarely in large eyes, in myopic eyes. When you introduce your phaco handpiece, the AC suddenly deepens. Then what happens is the pupil stretches a bit, the ring can dislodge. There is always a learning curve. So if you learn this in a dummy eyes, which is available, I tell you then how to make a dummy eye, and then it is very easy. And in a shallow anterior chamber, if I am offered a ring, I would like to have a BX ring because of its thin profile. But I always choose iris hooks most of the time for shallow anterior chambers. Now this is another case with an intumescent cataract, where the space between the iris and the lens is very small. The surface of the lens and the iris are snugly fit. So I went in, I did a small rexis here. Started off with my needle, but then I was not able to continue with the needle, so I decided probably this is a better option to go with your capsular rexis forceps utteratus. And once this is done, all my intumescent cataracts, I do this bimanual IA, go under and take out all the cortex possible from the anterior surface of the nucleus. And once that is done, you know that that capsule is down, way down. There is a big gap between the iris and the capsule. So you put in your BX ring introduced into the anterior chamber. Here I am using, finally yielded to that manufacturer constantly telling me to use this forceps. It's a 23 gauge forceps, opening up and down and not laterally. So you can see that it opens like a crocodile's mouth actually. Catch, twist to one side, engage one end, and then twist and get the other end in. See here, you catch, pull it to the center. So one edge is engaged, then you turn and put the other end. And when you go to the last one, always go through the other side. It is ideal to have some instrument through the other side port to support the eye while you are doing this. It will keep the eye in the center and you will be more comfortable. So you catch, bring it to the center, and one end you turn a bit, enter, and then you turn a bit here and enter. So that is all. This is actually very simple with this forceps rather than with Sinski's hook, unlike what I thought in the beginning. And because of its thin profile, this is one patient halfway through I lost the sonioles. They were very weak. So I stopped. I put in the capsule hooks. It's not possible to put capsule hooks with any of the other devices available today. So that is about BX ring. And tips to improve the outcome is, you have to differentiate between whether it is an elastic pupil or a rigid pupil. Rigid pupil, it is very tough to put any of these pupil expanders. Remember that when you inject fluid into the anterior chamber, BSS, if the pupil dilates a bit, that tells you that probably this is elastic. If it remains the same, then you will have to stretch. Now stretching, unlike what you do routinely, only stretch means you stretch to the limbus. But here, if you are stretching, you stretch only to 6.5 or 7 mm, 1, 2, 3, and 4. 4 stretches you should do. Very minimal stretches so that you will have only very small tears, so that pupil will remain round, even come back to normal and react. And always remember, whatever expander you use, including the iris hook, inject OVD below the iris and underfill the anterior chamber, not overfill. If you overfill, the iris is going like this. Remember, in high myopia, when you go in with the fluid, the iris goes like posteriorly and you get a reverse pupillary block. Similarly, it goes down, so there is no gap, and then you can injure the anterior capsule. iNova is the new kid in the block that is from Orolab. It's a pupil expansion device made of medical grade silicone. I used to use a ring to do my rexes called Veras ring. This is similarly like that, except that this ring engages 360 degree of the pupil with no pupillary distortion, and they give an injector, a simple injector. It gives you a diameter of 6.3 millimeters inside the overall diameter, and there are four positioning holes where you can use your Sinski's hook to introduce and to remove. And on the sides, it has got a groove 360 degrees, so that will engage the pupil all around, so there is no severe stress at any point which will damage the sphincter. So let us have a look at it. This is the injector that they give. I know a pupil expander. You push it in, and then you use your dialer to take it completely inside. Once it is inside, you catch the positioning hole and engage the pupillary margin. When two adjacent holes are engaged, the iris margin in between gets into that groove and sits there. Now it is absolutely round and stable there. I found that this is stable. You make a rexis which is slightly within this, because this is 6.3, you want only 5.5. So use this as a marker or a scale to make your rexis. So that is one additional advantage of having this iNova ring. And it doesn't interfere with your phaco handpiece. It doesn't interfere with your IOL implantation. And finally, to take out, inject OVD. After the lens is dialed into the bag, inject OVD and pull it in. I tried a new technique of pulling from both the sides. This is all more or less the same, because I generally don't like with these rings, any ring for that matter, when the iris goes into the ciliary body area. But here I tried, but then it's more or less the same. So it comes out, and then you can pick it up with your forceps. This is another case where I tried injecting with the injector itself. Once I went in, it doesn't go in completely with this injector. You draw back, you inject a second time, it goes little more, and with the third push, definitely it goes in, and then the procedure is the same. The disadvantage of the iNova ring is it's thicker, it's a thicker profile. So in very shallow ACs, I don't think we should be using this ring. But the advantage is it can be used multiple times. For a person in private practice, it can be ETO'd or autoclaved, and can be used multiple times. And you can use a subject fixated, coaxially sighted corneal light reflex to center your rexis by using this ring initially. And always remember that any form, wherever you are touching the iris, use more of steroids. Always remember this. And in situations where there are large PC runs and where there is solar dialysis, it is always hooks and never rings for me. With that, let me stop here. Thank you so much. And you can punch out actually small elastic materials. That hole comes to about 4 mm on a scale. And you can use your BX ring, used BX rings in your ring, and you can practice on this, a plastic ring, which you can stretch on a ring and keep it, and you can practice. If that helps a lot, do it whenever you want to go into rings. Thank you so much for your patient listening. Thank you, Cinema. Thank you.
Thank you, Jayaprasad sir, for that good videos and excellent presentation.
Sir, one doubt. Which one is comfortable for you, sir? Whether it is BHEX or this iNova ring?
No, iNova, they gave it to me for evaluation.
Okay.
I've done only very few cases. Cost is around 2,000 rupees.
Yes.
BHEX is around 1,800 if I remember right. But you have to buy 7,000 rupees worth of that forceps. But thinner profile has a definite advantage, I feel. And so I think if the AC is not shallow, you can go in with iNova. It's a good ring. Thank you.
Thank you, sir. Next, I invite Dr. Sai Kumar, sir.
Sir, one more doubt. What is your preferred method in mature cataract small pupil? Whether it is Coghlan's hook or iris hook or rings? Mature cataract, non-dilating pupil?
No, mature cataracts, with a small pupil. Yeah, you would have seen that I always do a small rexis before I touch the pupil. before I touch the pupil, unless it is really small. If it is about, say, 4 millimeters, I make a 3 mm rexis first, go with bimanual. I do not use a coaxial, I use a bimanual, and go in and aspirate out the cortex. So once that is done, then the capsule goes back. There is a big gap. Then it's my choice as to whether I have to use capsule hook or the B-hex ring. And then you go in and do your second rexis and then proceed like normal. See, in all mature cataracts, once you have completed your rexis, then it is like any other cataract.